And we used to attend that CME every year, and then way back in 2006, I think we started this doing Hematopoiesis. So over to you, Dr. Agarwal.
Thank you so much for the kind introduction and the kind words. And first of all, I apologize for not being physically present because of some problems in the family. And I'm extremely grateful to the organizers for permitting me to do this online. I'm going to speak to you on thrombotic microangiopathy. So microangiopathy and thrombotic, what it means is narrowing of the microvasculature, that is arterioles, capillaries, and the venules. And this kind of narrowing should be due to the thrombi. So that's thrombotic microangiopathy. In this, the pathognomonic finding is fragmentation of the RBC. It's such a sine qua non that if you do not see fragmented RBCs, probably it is very difficult to visualize that what is happening to the patient is thrombotic microangiopathy. That is what is meant by RBC fragmentation. You see cystocytes, the broken RBCs. This can happen even while collecting the blood through a narrow needle, but usually the percentage of these cells is less than 0.1%. And any patient who's got more than 2% of these cells is a significant RBC fragmentation. RBC fragmentation leads to hemolysis. Therefore, these patients would have drop in hemoglobin, indirect hyperbilirubinemia, high LDH, which is also due to some other reasons, which we'll come to, decrease in haptoglobin, which is once again a sine qua non to diagnose this entity, and marrow will respond by producing reticulocytes. So you've got RBC fragmentation together with evidence of hemolysis. So by now we talked about presence of cystocytes, microangiopathic hemolytic anemia, and all this secondary to thrombotic microangiopathy. So what we talked is that there is a narrowing of the arterioles or the small vessels. This leads to RBC fragmentation seen to you on the right side in this film. Because of the ischemia, organ dysfunction takes place. So patient comes with ischemic symptoms involving various parts of the body. And because these thrombi consume platelets, there is thrombocytopenia. As far as the organ ischemia is concerned, it could happen in the brain, heart, intestine, kidney. And these 4 organs are the most important organs involved. This is an entity which can often affect young women during pregnancy, and therefore there could be placental infarcts leading to fetal wastage. The clinical presentation in these 3 organs could be quite subtle, like confusion, or just abdominal pain and nausea, or just some kind of ECG abnormalities. Or they could be gross, like paresis, aphasia, dysarthria, convulsions. Patient may get severe symptoms suggestive of a severe intestinal problem, including infarcts. And lastly, there could be myocardial infarction, arrhythmias, or cardiogenic shock. Brain is most commonly involved, 60% of patients. GI tract, 1/3 of the patients, and heart in 1/4 of the patients. Moskowitz almost 100 years ago talked about this pentad, in which two things we already talked about: anemia, microangiopathy, hemolytic, and thrombocytopenia. We also talked about organ ischemia involving brain and kidney, and these patients, because of tissue injury, get fever. So the pentad, which was talked about 100 years ago, is no more an early sign or symptom of this disease, because if you wait for the pentad to appear, the mortality is extremely high. So what you need is actually only microangiopathic, hemolytic anemia, and thrombocytopenia. And of course, patient will come to you often due to the ischemic symptoms to some organ. The next question to answer is, why does the microvasculature thrombose? For that, you will have to understand certain basic components of the blood. The first thing to understand is the von Willebrand factor. And you all know that there is a clotting factor called VWF, and that's the structure of it. And I want you to concentrate on this violet part of this structure called A2. The second substance that you have to understand is an enzyme. It's a protease enzyme. It's called ADAMTS13. This ADAMTS13 has got various parts in its structure, and ADAMTS is a sort of abbreviation. There is a particular part which has been shown to you in this box, made up of interrupted line. Now, what this ADAMTS13 does is it joins to the A2 domain of the von Willebrand factor and cuts it. So von Willebrand factor is cut into small fragments by ADAMTS, joining to the A2 part of the von Willebrand factor. That's normal physiology. So we have got von Willebrand factor strand, we have got ADAMTS that is cutting the von Willebrand. Just the cartoon showing you that. Now look at this diagram to understand what happens in this disease. So first we again recapitulate the normal hemostasis, in which there is von Willebrand factor, there is ADAMTS. This ADAMTS is breaking von Willebrand factor into small fragments. Von Willebrand factor, with its capacity to bring the platelet to the vessel wall, causes thrombi. In normal physiology, these thrombi are just good enough to seal the capillary damage so that the blood does not ooze. There is no actual thrombus taking place in the circulation. But now imagine a situation that there is no ADAMTS13, as a result of which you have got large fragments, large fibers of von Willebrand factor, which bring the platelet to the vessel wall, producing these microthrombi. And this will be now in excess because there are these large multimers of von Willebrand factor. So the whole process, which is physiological to seal the capillary, is now pathological, causing blockage of the arterial capillaries in the veins. So in the pathophysiology of this disease, there is presence of ultra-large von Willebrand factor multimers. As we said that this is due to paucity or deficiency of ADAMTS13. So a diagnostic test is that ADAMTS13 level, which should normally be 50 to 150%, drops. Not only drops, it drops to below the level of 10%. Now, why does it drop to below 10%? So this disease is an autoimmune disease. If you got ITP, there is antibody against the platelet. If you got SLE, there is antibody against the nucleus. Now, this is an autoimmune disease where there is an antibody produced against this enzyme ADAMTS13. This is an IgG antibody, which is responsible for 90% of patients of TTP. 10% of patients, there is no antibody, but genetically, the ADAMTS13 gene is mutated. So it becomes dysfunctional. So whether it is acquired paucity or it is a genetic defect, the end result is the ADAMTS13 is not there or not working. So you have the multiples which are gigantic, which lead to excess thrombi which are made up of platelet and von Willebrand factor in our microvasculature. There are certain clinical and lab associates of this entity. Like many autoimmune diseases, this is a disease of females. Like many autoimmune diseases, this is a disease of young females. One doesn't know the mechanism, but it's more common in people or women who are obese. There is a HLA linkage, HLA-DRB 1*11. And there are certain triggers for a person to precipitate the thrombi. And these triggers are invariably those which raise the level of von Willebrand factor, even in normal physiology. You get infection, VWF goes up, inflammation, trauma, surgery, pregnancy, drug, cancer, and transplant. So very often a patient presents to you following one of these, which has triggered the thrombi. So we already talked about the acute symptomatology of TTP, seizure, stroke, heart failure, kidney failure, and if the platelets are very low, bleeding. Certain patients can have chronic symptoms. They may be very subtle TTP. They may just come to you for headache. And when you do the CBC, you find the hemoglobin is low, platelet is low, RBC is fragmented, and hemolytic test is positive. And then you do further investigation, you find ADAM-TS is low. Somebody may come to you with recurrent abdominal pain, that's all. And somebody may come to you with brain fog. What it tells you is that the CBC is the starting point, because these are non-specific clinical symptoms. CBC take care, the hemoglobin is 11, the bilirubin is 1.3, the haptoglobin is slightly less, the retic count is 5%, and there are few cystocytes, then you are closer to make this diagnosis. Like an ITP can be a lifelong disease, TTP can be a lifelong disease, and the long-term manifestations are listed over here. So these patients have to be watched out for the rest of their life to pick up the recurrence happening at infrequent intervals. And you can intervene and abort that clinical recurrence. And therefore, it's important that you follow up this patient reasonably closely. I mentioned that the TTP, besides thrombi, can cause bleeding. And this bleeding can be into organs like heart. It can be in the skin, as you see over here. And if the platelet is very low, there can be large bruises. By now, you must have understood how to investigate these patients. So there's evidence of hemolysis, evidence of RBC fragmentation. So you've got reticulocytosis, absent haptoglobin, raised LDH. Raised LDH also comes from the tissues, not necessarily from the red cells, because organs are ischemic. And the Coombs test has to be always negative. To differentiate from DIC, the PT, PTT, fibrinogen are all normal, because this is not DIC. The damage to the kidney is in the form of proteinuria, hematuria, and subtle rise in creatinine. Creatinine usually does not go beyond 2. The cardiac drop may be high, ECG changes in 10%, and then the specific test, ADAM-TS activity less than 10%, and then its cause, either autoantibody or the gene sequencing to show you genetic mutation. So this is a complete summary of investigations that you should do. Now, ADAM-TS level will not come to you for clinical diagnosis overnight. It may take days. So there is something called plasmic score, which tells you that this is likely to be TTP, and please immediately do the plasma exchange. Platelet count very low, score of 1. Creatinine not very low, score of 1. INR not very high, score of 1. Presence of hemolytic features, score of 1. Absence of cancer and absence of transplant setting, score of 1. And then there is some genetic condition where the MCV is high, so less rise, no rise in MCV gives a score of 1. So there are a score of 7. And then you divide them into low risk, intermediate risk, and high risk. Intermediate and high risk, you will do the plasma exchange immediately till you get the level of ADAM-TS 13 and then decide what to do next. Differential diagnosis of this entity is plenty, but basically thrombotic angiopathy can occur due to hemolytic uremic syndrome. In children, there is typical HUS. In adults, there is atypical HUS. Then there are various causes of HUS or secondary HUS, and sometimes it can be idiopathic. And we are not discussing this entity, so we will not go to the further details. The last part of my talk is related to the management of this entity. The management of this entity, most important is plasma. If you do not have an access to plasma exchange, give plasma, because that plasma will supply ADAMTS13. And because you are supplying ADAMTS13, von Willebrand factor will be broken down and the process will be arrested. If you have an access to plasma exchange, immediately do plasma exchange, because that not only will supply ADAMTS, it will also remove these large multimers of von Willebrand disease. So efficacy will be double. You know the procedure of plasma exchange pretty well, and in nephrology unit can help you. And long ago, it was clearly shown, 30 years ago, that the plasma exchange is superior to plasma infusion. So you can do plasma infusion in a peripheral place in the mid of night, weekend, but immediately shift to a patient to a place where plasma exchange can be done. And you should not wait for confirming the diagnosis of TTP for doing plasma exchange, because this is severe. This has to be done on daily basis for a couple of days. Because it's an autoimmune disease, the acquired one, 90% of patients, so you use corticosteroids. And because corticosteroids are not enough, all patients are also giving another immunomodulatory agent, that is rituximab, which is anti-CD20 antibody. So the first line treatment of this disease is all over the world, immediate plasma exchange or at least plasma infusion, immediate corticosteroids, immediate 1 dose of rituximab, then confirm your diagnosis and continue the management. If your patient is not doing very well, despite all this, you can use other immunomodulatory agents, which include cyclophosphamide pulse therapy, vincristine, bortezomib, and very occasionally splenectomy. There is something new on the horizon, and that is another monoclonal antibody called caplacizumab. What exactly is caplacizumab? It's a monoclonal antibody which inhibits the interaction of von Willebrand factor multimer with the platelet. You saw that the von Willebrand factor multimer brings the platelet to the capillary endothelium. So that action, the interaction is blocked by this particular antibody. It's really genius of the scientists to develop this. Another new drug knocking your door is, instead of giving plasma as the source of ADAMTS13, recombinant human ADAMTS13 has been developed. At the moment, it is not available worldwide. It's not available in India at all. It's not available in large parts of the country. And at the moment, it is licensed only to be used for genetic TTP, because that's the condition where immunomodulation will not work. So you'll have to supply a functional ADAMTS13. So overall management part consists of plasma therapy, preferably plasma exchange, steroids, rituximab, other immunomodulator, caplacizumab, recombinant ADAMTS13. This is a cartoon telling you the same thing. There is anti-ADAMTS13 autoantibody. So you give steroid, rituximab to all, and if necessary, give cyclophosphamide or vincristine or bortezomib or do splenectomy. To remove the large molecule and to supply the ADAMTS, you do therapeutic plasma exchange. You can give ADAMTS13 recombinant for genetic cases, and maybe one day even for the acquired cases. So recombinant human ADAMTS13 is there. And lastly, caplacizumab. So this is a 4-pronged attack to control this disease. What should not be done? One is platelet transfusion. Unless the patient is dangerously bleeding and he may die or have morbidity due to bleeding, you will not give platelet to this, because giving platelet is allowing more thrombi to develop. And because you've got such powerful immunomodulatory agents today, when there were only steroids, we used to do splenectomy. But now steroids, rituximab, pulse cyclophosphamide, mycophenolate, bortezomib, vincristine, you've got so many things that splenectomy in the treatment of this has become obsolete. So you don't do splenectomy. What's the prognosis of these patients? The prognosis is guarded. It could be good, bad, or ugly. Good means a patient may be cured, like an acute attack of ITP. One episode, you manage it successfully, patient survived, and she never gets it again. It could be bad, that is relapsing. It could go on relapsing at months and years interval for the rest of the life of the patient. And it could be very ugly. Patient may die in the first episode or at the time of relapse. In the best of the center in the Western world, in the center who do only one disease management, TTP, and there are centers like this, the mortality is 10 to 20%. You can imagine what must be happening in the rest of the world and India. What's the future of this entity? Future is that probably the cumbersome plasma exchange to remove the von Willebrand large molecules and to supply the ADAMTS may be got rid of by giving caplacizumab and rituximab. Rituximab as an immunomodulator to prevent the formation of antibody, and capla to prevent the von Willebrand factor from acting. These two combinations may be that you don't need plasma exchange. This is under research. So the learning point of my talk today, I'll summarize in 2 slides. So you have a patient who has got thrombocytopenia, and that thrombocytopenia is severe, usually below 30,000. So that's the first requirement. Second, patient has got hemolytic anemia. So anemia, bilirubin, haptoglobin, LDH, reticulocytosis. And this hemolytic anemia is microangiopathic, so there are cystocytes. So these 2 are essential part of the starting of the thinking of the process of TTP. Patient usually comes to you for organ ischemia, producing symptoms in the brain, heart, GI tract, or kidney. If you do a biopsy, Moscovitz had done lip biopsy to show this. Nowadays, we don't do biopsy. This thrombi are made up of only platelet and von Willebrand factor, not fibrinogen, not red cells. And they are present in the arteriolar and capillaries, not in, say, middle cerebral artery and all that. Then ADAMTS 13 level, when the report comes to you, it is less than 10%. This is the only specific biological marker. And in 90% of the cases, you can document ADAMTS autoantibody, and in 10% of cases, you can document the mutations. Mostly it's a disease of adults, though it can affect children and elderly. Females outnumber males, very often obese, and in US, blacks are more affected than whites. It's an acute disease, but it has a relapsing tendency. Treatment is daily therapeutic plasma exchange for a minimum of 5 days and sometimes 10-15 days. The end point is that the platelet count is normal for 2 consecutive days and the LDH is normal for 2 consecutive days. Then you stop plasma exchange and keep monitoring these tests twice a week. If platelet is dropping again or LDH is rising again, you again restart the plasma exchange. Sometimes we have gone on doing this even for 6 months. Steroid, half a gram or 1 gram of methylprednisolone daily for 3 days, and then taper 60 milligram of oral prednisolone, and then taper it very slowly over weeks and months. Rituximab once a week for 4 doses, and then you may require it later on. Refractory cases, bortezomib twice a week, pulse cyclophosphamide 1 gram, vincristine 2 mg, cyclosporine, and very rarely splenectomy. New drugs, Capla and recombinant. Long-term follow-up, very carefully follow up this patient. You want to prevent the relapses. You want to identify that something is happening by looking at the cystocyte or low platelet or hemolytic parameter. And if it's happening, immediately administer a dose of rituximab. It can abort the attack. To identify associated other autoimmune disorders, like ITP may be due to SLE. TTP may have other systemic autoimmune disorders, so look for them. And because you are getting damaged brain, there can be long-term psychophysical sequelae. There's a last study coming from Oklahoma documenting that the suicidal rates were very high following TTP patients over the next 3 decades, showing you what it can do to a psyche. So be smart. This is a real, very, very charming story. This is a young doctor who diagnosed TTP. He's a hematologist. This is the patient of TTP whom he salvaged, and they got married and they're happily living together. Thank you so much for giving this opportunity to me.
Thank you for an excellent talk on TTP. Any questions from the audience? So I will ask one question, because Adams is the test. Usually it takes a lot of days to get the report right now, and sometimes patient is already given steroids and plasma already. So then does it have any role for diagnosis if patient is already partially treated?
So if you don't have a firm diagnosis, your patient has received plasma exchange and steroids. So what we do, and this is a very common scenario. So what you have put is a real story. So what you do is you just keep looking at the platelet and the LDH. Once they normalize for 2 days, you stop plasma exchange. You start tapering the corticosteroid. You carefully keep looking at these parameters. If the process is recurring, then you just continue the treatment. You restart the exchange. You don't decrease further steroid doses. You may give more rituximab, etc. So it's a clinical diagnosis of TTP, which you and me do in large number of patients. And then we tell them that this is a TTP, irrespective of availability of the ADAMTS test or not availability of that test. Later on, if you have an access, you can do this test. You can look at the autoantibodies, at least to know whether there's a chance of this patient getting relapsing disease, which is quite common. So you can keep looking at that. So what your put question is absolutely the common scenario. To have the ADAMTS 13 level is much less common. To diagnose this patient and treat this patient without ADAMTS 13 or the antibody levels is the scenario of the day. Only thing is you cannot collect the blood sample after you have done the plasma exchange. So if you are suspecting TTP, please collect the blood sample. Say it is Saturday evening and the lab is going to take the sample on Monday. So collect the sample, store it properly, and Monday you send it to that lab, because after plasma exchange, you'll have to wait for the whole treatment to be over and then collect the blood samples. We are fortunate because National Institute of Immunohematology is next door and they're doing this test at throwaway price for us. We have to only collect the sample carefully before we start the plasma exchange.
Yeah.
Sandeep, you'll have to repeat the question. I cannot hear him.
No, he is saying that is it better to use fresh frozen plasma or cryo-poor plasma?
Okay, so initially we all used cryo-poor plasma because cryo contains foreign Willebrand factor. So I remember in 1980, 90, 2000, we did that. Now there is ample data to show that you don't have to have cryo-poor plasma. And as you know, with factor 8 availability, preparing cryo-free or cryo-poor plasma in the blood bank has disappeared. Now nobody makes cryoprecipitate by and large. So if you wait for cryo-free plasma to be available, you may not be able to do plasma exchange. And scientifically, it is not required. So we have abandoned that. We use just fresh frozen plasma.
Thank you. Any other questions? Thank you very much, sir.
Okay. Bye-bye, Sandeep. And once again, thank you. And I again excuse myself for not being physically present. The loss is mine. Thank you.
Actually, Michael stage of the soil knowledge, who will teach us the art of balancing liver quality. To you, sir.